Secondary hypertension refers to an elevated blood pressure caused by an underlying identifiable and potentially reversible condition. While long thought to affect only 5 to 10% of patients, clinical guidelines highlight that its true prevalence may be as high as 10 to 35% in specific subsets such as those with severe or treatment-resistant hypertension. Recognizing secondary causes is crucial. Delayed diagnosis can lead to irreversible vascular damage and disproportionate hypertensive-mediated organ damage. Screening the entire hypertensive population is neither cost-effective nor clinically practical. Investigation should be targeted toward patients presenting with specific red flags. Resistant hypertension, uncontrolled blood pressure despite adherence to optimal doses of 3 antihypertensive agents from different classes, including a diuretic. Age of onset, abrupt onset or severe hypertension developing before age 30 or after age 55. Acute destabilization, sudden severe loss of BP control in a patient whose numbers were previously stable and well regulated. Disproportionate target organ damage, severe target organ damage, example advanced retinopathy, left ventricular hypertrophy or renal dysfunction that seems excessive for the known duration or severity of the patient's high blood pressure. Specific clinical clues, unexplained hypokalemia, abdominal bruit, or episodic spells of sweating, palpitation and headache. Go through some important causes of secondary hypertension and their management. Primary aldosteronism, Conn syndrome. Once thought rare, primary aldosteronism is now recognized as one of the most common endocrine causes of secondary hypertension, particularly prevalent in patients with moderate to severe or resistant hypertension. The primary screening tool is aldosterone-renin ratio. Guidelines emphasize that screening should occur even in the absence of hypokalemia. To avoid unnecessary screening barriers, patients can continue most of their baseline antihypertensive therapies during testing, with the critical exception of mineralocorticoid receptor antagonists like spironolactone or eplerenone, which must be discontinued. A positive aldosterone-renin ratio is confirmed via dynamic testing, example oral sodium loading, followed by a CT scan of adrenal glands and adrenal vein sampling to determine lateralization. Management. Unilateral disease like aldosterone-producing adenoma, laparoscopic adrenalectomy offers a high rate of clinical cure or substantial improvement in BP control. Bilateral disease, example bilateral adrenal hyperplasia, managed medically using mineralocorticoid receptor antagonists like spironolactone or eplerenone to directly block the downstream effects of aldosterone excess. Renal parenchymal disease, chronic kidney disease, functions as both a major cause and a direct consequence of long-standing systemic hypertension. Routine baseline assessment requires checking the estimated glomerular filtration rate, that is EGFR, alongside a urinary albumin to creatinine ratio to quantify macro or microalbuminuria. Management centers on rigorous BP control, typically aiming for a target of less than 130 by 80 millimeters of mercury and slowing renal decline. Renin-angiotensin-aldosterone system inhibitors, specifically angiotensin converting enzyme inhibitors or angiotensin receptor blockers, are the preferred first-line agents due to their internal antiproteinuric and renoprotective properties. Caution and close monitoring is needed to exclude worsening of hyperkalemia and renal status when these medications are used. Renovascular hypertension, renal artery stenosis. Reduced perfusion across one or both renal arteries triggers the renin-angiotensin-aldosterone cascade, driving severe renin-dependent systemic vasoconstriction. It manifests primarily via two distinct pathologies. One, atherosclerotic renal artery stenosis, typically seen in older adults with generalized cardiovascular disease. Two, fibromuscular dysplasia, a non-atherosclerotic vascular disease seen predominantly in younger female patients. Screening and diagnosis. Non-invasive imaging via renal artery duplex ultrasonography, computed tomography angiography, that is CT angiography, or magnetic resonance angiography serves as the primary diagnostic approach. A classic clinical clue is an acute decrease in estimated glomerular filtration rate of greater than 25% shortly after initiation of an ACE inhibitor or ARB. Medical management. Optimized medical therapy using renin-angiotensin-aldosterone system inhibitors, statin, and antiplatelet agents is preferred for most patients with atherosclerotic renal artery stenosis. Caution: ACE inhibitors and ARBs are contraindicated in cases of true bilateral renal artery stenosis or stenosis affecting a solitary functioning kidney. Revascularization. Percutaneous renal artery angioplasty with or without stenting is indicated for patients with fibromuscular dysplasia or individuals with atherosclerotic renal artery stenosis who experience recurrent flash pulmonary edema, that is Pickering syndrome, refractory heart failure, or progressive unexplained renal failure. Obstructive sleep apnea is highly prevalent, identified in a vast percentage of patients with resistant hypertension. Intermittent nocturnal hypoxia and hypercapnia drive sustained sympathetic nervous system activation, which often eliminates the normal nocturnal dipping phase of blood pressure. Screening and diagnosis. Initial clinical evaluation using validated screening tools such as the stop-bang questionnaire should be definitively confirmed via nocturnal polysomnography, that is sleep study. Stop-bang questionnaire is an 8-item screening tool used to assess risk for obstructive sleep apnea. A score of 5 or higher indicates a higher risk for OSA. Management. The mainstay of treatment is continuous positive airway pressure CPAP therapy. While CPAP provides modest net reductions in overall 24-hour ambulatory blood pressure measurements, it significantly improves overnight cardiovascular profiles, daytime somnolence, and metabolic parameters. This is coupled with aggressive lifestyle interventions focused on weight loss. Drug or substance-induced hypertension. A broad range of prescribed over-the-counter or illicit substances can cause or severely exacerbate existing hypertension. Common culprits include non-steroidal anti-inflammatory drugs, oral contraceptives, systemic corticosteroids, sympathomimetics such as nasal decongestants, calcineurin inhibitors, and stimulants. Screening and diagnosis. Detailed medication reconciliation including active screening for over-the-counter supplements and illicit substances. Management. Where clinically feasible, the offending agent should be down titrated or completely discontinued. If the medication is essential, example necessary immunosuppression or chemotherapy, baseline antihypertensive regimens must be aggressively optimized to counteract the drug's pressor effects. Here is a summary of secondary hypertension screening. Primary aldosteronism, resistant hypertension, unprovoked hypokalemia, though often normokalemic. First line screening tool, aldosterone-renin ratio. Renal parenchymal disease, primary clinical clues, elevated serum creatinine, known kidney disease, history of diabetes. First line screening test, eGFR and urine albumin to creatinine ratio. Renal artery stenosis, abdominal bruit, flash pulmonary edema, acute eGFR drop more than 25% with ACE inhibitor or ARB, first line screening test, renal duplex ultrasound, CT angio or MR angio. Obstructive sleep apnea, snoring, witnessed apnea, daytime sleepiness, non-dipping nighttime BP pattern, test polysomnography, sleep study. Pheochromocytoma, paroxysmal spells of headache, profuse sweating and palpitation. Test plasma free metanephrines or 24-hour urinary metanephrines. Cushing syndrome, moon facies, central obesity, proximal muscle weakness, white purple striae. Test 24-hour urinary free cortisol or late night salivary cortisol. Aortic occultation, BP differential between upper and lower extremities, delayed femoral pulses. Echocardiogram or CT-MR chest angiography.